The next few slides talk about transposition of the great vessels. This is kind of an interesting heart defect. The blood's going to go from the right atrium to the right ventricles, out to the aorta, then back to the right atrium, right ventricle, aorta, out to the body, right atrium, right ventricle, aorta, out to the body. It's never going to go to the lungs because it's not going to the pulmonary artery, it's going to the aorta. And then the left side of the heart, it goes from the left atrium to the left ventricle to the pulmonary arteries, and then the left atrium, left ventricle, pulmonary arteries, left atrium, left ventricle, pulmonary arteries. So what you have is almost like the right side of the heart is circulating over here, the left side of the heart is circulating over here, and they never mix. We need them to mix somehow, otherwise the baby's not going to survive. So we're going to be giving prostaglandin E to maintain that patent ductus arteriosus, so that as the blood goes from the left atrium, left ventricle up to the pulmonary arteries, some of it will be going up to the aorta, and that will actually be the oxygenated blood coming from the left side, so that we can mix those somehow. We can also create a ventricle septal defect, but this kid was definitely going to need surgery because the aorta and the pulmonary artery have switched places. One thing to think about when trying to maintain a patent ductus arteriosus is oxygenation. You learned last semester, and then we talked about it with part 1 of this chapter in the PowerPoint. We talked about a PaO2 of 45 to 50 is really what it needs to close the patent ductus arteriosus. Therefore, if we need that PDA to stay open, we better not get that oxygen too high, otherwise it's going to close. So we have to keep our PaO2 actually around 45 to maintain a PDA. We have to watch out for that. This baby's going to be blue, and that's okay. Their sats are going to be 60, and that's okay, because that is what's keeping them alive at this point. It's hard to do because you're going to want to fix it, but you're keeping them alive. If they need a PDA, we need their sats to be 60% or less, and they're going to be cyanotic, and you're just going to have to trust that. And then we talk about if this baby's on a ventilator, which they probably will because the heart's not going to be working very well and they're going to be going in and out of surgery. If they're on a ventilator and the blood flow is not going to the lungs like it should, make sure you watch your compliance. Because there's not as much fluid in the lungs, because there's not as much blood pressure in the lungs, then their compliance is going to be really high, and it's going to be easier to accidentally overdistend the lungs because, again, there's not enough fluid, the lungs move easier, and we can cause barotrauma by creating too much PIP. Therefore, normally with the baby, we'll have a PIP of about 25 and a PIP of 4. We talked about that last semester. So if your PIP is normally about 25, you might shoot for a PIP of 15, 16, 17, 18, probably not much higher than that, so that we do not cause overdistension. You're going to check your x-rays, make sure that diaphragm's not flattened. If your diaphragm is flattened, you've overdistended the lungs. And we're going to watch for that spacing between the ribs, because the ribs can actually grow apart pretty quickly, like within even a matter of hours, you can see spacing increase between the ribs if you have overstretched the lungs. So you're going to be watching all of those things.